Good. So I thought I'd, just to set this next session in context, would revisit Francis's paper from a decade ago. Sorry, Francis. Because although premature, a number of things were set in terms of foundations that lead us up to this point, I think, very nicely. So yes, it cost $10 million to do whole genome sequencing at that time, but clearly the NIH was putting in place at that point the goals that would drive this cost down to $1,000 per genome. At that time, acute care hospitals, only about 13% were using EHRs at the time, but ONC was created in 2004 at the same time point, and along with the high-tech effort 5 years later, actually did a lot to sort of push the adoption of EHRs and the rapid adoption that we're seeing lately. We still do, even then did at that time, mostly measure in the epidemiologic framework our work via self-report. But in 2004, the NIH launched the PROMISE initiative, the Phoenix initiative, both to make our self-report measures more standardized, more precise, and with less respondent burden. As well, the Gene, Environment, and Health initiative that was an effort to try to move some of the things that we typically measure via self-report onto some passive sensor technologies in the future. We had accelerometers around for quite some time, but it was in 2004 that the Actigraph, the first research-grade accelerometer, was put on the market. If you were really exciting and you were cutting edge in the mobile tech field, you bought yourself a Motorola Razr. It was the hottest phone out there in 2004. And the number of apps you could download onto your iPhone was zero. Because it would be actually 2007 before the iPhone came out, and then 2 years later still before the Android came out. So we've moved a long way. And so to set this up, I just want to point out that the presenters for this next session are going to talk a bit about the new technologies that are available to us, how we can leverage them for cohort studies. But I want to remind us that we're going to really be enamored with all the shiny new hammers, but we also have to pay attention to the nails. So can we use these mobile health technologies to better characterize the phenotypes? Can we use them to better characterize the outcomes we're looking for, to better characterize the treatments, to extend our treatment predictors beyond genomics alone, to more precisely and intensively, and I mean longitudinally intensively, characterize our behavioral risk factors and environmental exposures that might interact or even overwhelm some of the genetic signal we're looking for? And can we fully engage participants as partners using these technologies? So with that, I will turn it over to our first speaker, Peter Tippett from Verizon. Will speak on how Americans use technology to track and understand their health. Peter?